Welcome. I am Terry Tropin, and today I'll be discussing coding a hospital visit using the new 2023 guidelines for CPTs, evaluation, and management codes. So let me start with a little bit about myself. I have a master's in healthcare administration technology, informatics from University of Maryland Global Campus, and have RHIA and CCSP certifications. Also, I'm an AHIMA approved ICD-10 trainer. I taught health information technology at Montgomery College for over 20 years. I've also written books on coding. These grew out of my teaching when I was making study guides for my students. So these books summarize the coding guidelines, including the 2023 changes, including the March changes also. And I have one on evaluation and management, one on CM, and one on PCS. These are available on Amazon. So this is what I'm going to talk about in this presentation. I'll present a hospital case and then go step by step through the process of selecting the correct code. So this includes determining the medical decision making, determining the correct code if using medical decision making, MDM only, and then determining the correct code by using time only. So this case is in a hospital visit setting. Remember that inpatient and observation services are now in one category of codes. It used to be they were separate, but now they're not. So this category is 99221 to 99239. But there are subcategories. You have initial services, subsequent services, and discharge services. There's also admit and discharge services. So except for the discharge services, these codes are selected based on either medical decision making or time spent with the patient or reviewing the notes. So remember that in office or outpatient visits, there's a range of time, like 19 to 22 minutes. For these codes, it's a one specific time which must be met. That's the minimum amount of time. It may be exceeded. There may be a little bit more than that, but you must meet at least this level of time. So let's look at the case. So this patient was admitted yesterday as an inpatient by Dr. Jones. This patient was continuing on continuous ambulatory peritoneal dialysis due to her end-stage renal disease. She's seen today by the same physician. Her weight has fluctuated to some extent dependent on some GI losses, cause not determined. Her weight dropped to 154 yesterday. She was given some saline boluses through the night, and this morning she's reasonably stable. Her weight is up to 158. She's been on Unison 4, an antibiotic, due to elevated white count and suspected sepsis. She also has hypoalbuminemia due to the kidney disease. Over the last day or so, she's had problems with hypotension related perhaps to initial bradycardia and then subsequently to recurrence of her atrial fibrillation with a more rapid rate. Okay, so more on this case. Patient, this is the examination done today. Patient has no congestive failure and no pain. Her abdomen is soft, fluid clear, cultures remain negative. A laboratory test was ordered for possible infection. Physician ordered tests for kidney function and to see the efficacy of the dialysis. Physician notes the illness is still very serious. She is not thriving. She's not eating well. The prognosis at this point is extremely guarded. So the physician ordered an esophageal gastroduodenoscopy to be performed today and a CT scan of her abdomen tomorrow to try to investigate the true core problem that she has, basically the GI losses. Time spent with patient and reviewing notes, 45 minutes. So we need to know some information from here, but not all of it. What I would suggest is underlining the important parts of the case. If it's online, then you need to make notes. You don't want to have to keep reading this over and over again to pull out what you need to know. How do you need to know what to underline? Well, that just comes from practice and being more familiar with the codes. So this is what I underlined in this. Patient was admitted yesterday. That's important. She has end-stage renal disease and has ambulatory peritoneal dialysis. Her weight is fluctuated. She's been on unison, elevated white count, suspected sepsis, hypoalbuminemia, and hypotension, bradycardia, atrial fib. So this is what you need to know. All the information is important, but what you need to know for this case in order to select a code is the part that's underlined here. So what else do you need to underline? Well, lab test was ordered for possible infection, test for kidney function and efficacy of the dialysis, time spent with patient and reviewing notes, 45 minutes. So the record also discusses drug management. Discussion of possible drug management with Dr. Jones from someone in cardiology. The medical record indicates the patient is intolerant to digoxin and quinidine. The doctor is discussing with cardiology, what do you think we should do? Use a different drug? Use more of the drug? What do you think we should do? So this is a discussion. Physician decided to discontinue the unison and pay attention looking for signs of infection. Also decided to increase her epigen slightly to push her hemoglobin up a little faster. This will be closely monitored because of possible side effects, serious side effects, some involving the heart, which has already got heart issues. So results of changes in the medications will be reviewed overnight. Finally, the physician ordered some diagnostic tests, some procedures. She'll get a diagnostic esophagogastroduodenoscopy today. The results will be reviewed and interpreted. Tomorrow, she's going to get a CT of her abdomen. So this is a review. So what does she have? End-stage renal, hypotension, bradycardia followed by atrial fib, hypoalbuminemia, and weight loss. The prognosis, she is seriously ill. She's not thriving. She's not eating well. Prognosis is called extremely guarded. So how do we select for this code? Well, first, let's look at medical decision making. Now remember, the components of medical decision making are 3 of them that make up the correct medical decision making level. So you have number, complexity of problems addressed at the encounter. What's wrong with the patient and how serious are they? How serious are the conditions? Then you get amount and complexity of data reviewed and analyzed. What does the physician need to know? What kind of information does the physician need to collect in order to either diagnose the problem or decide how to treat the problem? And finally, you get risk of complications and our morbidity, mortality of patient management. This is of the treatment, how the patient is managed, not of the problem, because the problem is up here. So these 3 components make up the 4 levels of medical decision making: straightforward, low, moderate, and high. So let's start with the first component, problem addressed. So here's what we have, and let's think back on that case as we go through these. Straightforward level, 1 self-limited problem. Well, that's not the case. Low, 2 or more self-limited minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness. 1 stable acute illness, 1 acute uncomplicated illness or injury. Doesn't sound like that one either. This is, she's more seriously ill than that. So moderate, you go up to 1 or more chronic illness with exacerbation, progression, or side effects of treatment. That sounds more familiar with this case. 2 or more stable chronic illnesses, 1 undiagnosed new problem with uncertain prognosis, 1 acute illness with systemic symptoms, and 1 acute complicated injury. Some of that. So, but look at high. High is 1 or more chronic illness with severe exacerbation and 1 acute or chronic illness or injury that poses a threat to life or bodily function. That sounds like it to me. So let's look at problem addressed and what level we're going to choose. This patient has a number of serious conditions, and these are listed over here on the left. And compare this to the description of problem address level for high. 1 or more chronic illnesses, severe exacerbation, threat to life or bodily function. They said the prognosis is not good. She's got a lot of issues. So we're going to say that this is high. So let's move on to the next element, data reviewed. Amount and complexity of data to be reviewed and analyzed. So you have straightforward, minimal, and none. Well, that's not the case. Low, you have either category 1 or category 2. Category 1, any combination of review of external notes, review of results of each unique test, ordering each unique test. Category 2, independent historian. For moderate, you need to meet at least one of 3 categories. Category 1, any combination, and these are the same except for this part, independent historian. And here, this is lumped into category 1. For this one, it's its own separate category, category 2. Category 2 for this one is independent interpretations of tests. Category 3, discussion of management of test interpretations. Now, high has the same categories as moderate, but the difference is 2 of the 3 categories, at least 1 of 3 categories. So this one you only have to meet 1 of these 3 categories. For high, you have to meet 2 of these 3 categories. So where would this case fall? I say this is also high level. So you meet at least 2 of the 3 categories. Category 1, 3 of the following. Category 2, category 3. So what we have is review of results of 2 tests, kidney function test and culture for infection. Review and interpretation of results of esophagogastroduodenoscopy. So you can count each of these tests separately. How do we know this? Look at the definitions in the E&M guidelines, combination of data elements. The description states each unique test. 3 different tests, 3 different elements are counted. Also remember that a review is counted only as ordered and are reviewed, ordered or reviewed. An interpretation can be counted once for being ordered and once for being reviewed. So what's the difference? A review is like a test, a pregnancy test. She either is or she isn't. There's no interpretation for that in most cases. For the esophagogastroduodenoscopy, that's going to take some review of the results to try to come to a conclusion about that. It's much more involved, and therefore it can be counted. You count the ordering and the review. For category 3, we have the discussion with the cardiologist, and that's right there. Okay, let's move on to risk, the final component. Complications and morbidity or mortality of patient management. This is the risk of the treatment, not the condition. So you have straightforward, minimal risk of morbidity, mortality. That's not it. Low risk of morbidity, mortality. For moderate and high, they give specific examples. They don't give general descriptions. So moderate prescription drug management, well, we've got some drugs going on here. Decision regarding minor surgery, well, yeah, we've got some minor surgery, the esophagogastroduodenoscopy. Decision regarding elective major surgery, no, not really. Diagnosis or treatment limited by social determinants of health, okay? So, kind of. So for high, drug therapy requiring intensive monitoring for toxicity. Remember that we said the Epigen had a lot of serious side effects, so that's why this seems to fit the best. Now, with elective major surgery, no, it's not, but the toxicity is enough to make it high. So let's look at the risk. The Epigen has serious side effects that can lead to death, so therefore it's high. And the decision for the esophagogastroduodenoscopy, that's not major surgery, but just because of this, the toxicity issue, this can be reported as high. So, medical decision making, this is pretty straightforward for this one. You got problem addressed as high, data reviewed as high, risk is high. You put them all together and you get a high level of medical decision making. But you also remember these can be done by medical decision making or time spent with patient. So we go back and we see time spent with patient reviewing notes was 45 minutes. So what code are we going to select here? So we narrow down all of the E&M codes and we get to hospital inpatient codes, 99221, 99239. So that's the category. The subcategory within that is subsequent hospital visits. Remember, one of the things we underlined was that she was admitted yesterday. So this is a subsequent visit. 99231, 99233. So let's look at those. Well, you look at these codes and you see that 99233 is that high medical decision making. 99232 meets the minutes. Now you said, now wait a minute, it said 45 minutes. Well, that's true, but it's got to meet the 35. So it was at least 35. It's 45 minutes. It's more than the 35, but not up to the 50 minutes. A minimum of 50 minutes needs to be done for the 99233. So if you're going by medical decision making, it's 99233. If you're going by time, it's 99232. So obviously, we're going to pick the bigger number, the one that pays more, the more involved code. So for this case, we're going to report 99233. Okay. So that completes the video. Here again are the books that I wrote. And here's where you can get them. You can just go on Amazon and turn to books and then type in my last name. That might be the easiest. But these are listed in the introduction to this video. I've got podcasts. If you'd like to ask me questions or make a comment, I'd love to hear from you. Here's my Facebook page. Here's my email. If you'd like a copy of the slides, give me a thanks and I will and send your email address to Terry Tropin, and I will be more than happy to send these to you. Thank you so much for listening. Remember that I have a practice 1, which is on an office visit, and I will do additional practices in the future. Thank you.